So she was a 52-year-old female, presented in August 2020, small lump in the right breast with a fit performance status. On examination, a subclavicular lymph node was there. Ultrasound and mammography showed a Barrett's 5 with an axillary and subclavicular ipsilateral lymph nodes. Looked like a local-regional disease, but when you do a scans, you find out the upstaging of the disease. Next slide, please. And you get she was on biopsy a hormone positive, strong hormonal positive, ER positive, PR 10% positive, and HER2 negative. Next slide, please. So CT was done, which was suggestive of again lymph node and subclavicular metastasis. PET was done, which was showed that there were mediastinal lymph nodes uptake and a thoracic vertebral metastasis. Next slide, please. So she was started on September 1st, 2020 with letrozole abemaciclib. There was only one episode of grade 3 neutropenias, no dose reductions done. Next slide, please. On the next follow-up, she had a complete regression of a subclavicular lymph node. There was the breast centimeter, the lesion was completely disappeared from 3 centimeter to 1 centimeter. There was a complete regression of the previously active lesions on the PET scan. And that response was continued in the further subsequent visits also. In March 2021, there was a clinical and metabolical complete response. Next slide. And you could see on those scans, all lytic areas, all light up areas were completely disappeared. And even after 6 months of the therapy, she didn't show any signs of the disease activity anywhere across. Next slide, please. So she took a second opinion from the surgical oncologist because she was having an exceptionally complete response outside the area. And she was offered a radical surgical mastectomy and axillary lymph node dissection. On histological examination, there was a residual tumor of 1.5 centimeters with negative surgical margins. The 5 involved lymph nodes were completely positive among the 13 which were excised. Next slide, please. After the surgery, she took a second opinion with the radiation oncologist. She received a radical radiotherapy and a stereotactic radiation on the 7th vertebra. Next slide, please. And then she came for an adjuvant treatment to me. And again, I prescribed her again with letrozole and abemaciclib. And patient is still doing well even after 21 months of the therapy. Brilliant, complete metabolical and clinical response. Even after the treatment of it. Next slide, please. So we always have these common situations where we have an oligometastatic luminal breast cancers. We have a tendency to start chemotherapies, but CDK4/6 inhibitors, as we know, have revolutionized the way we treat our breast cancers. And that's why I choose the lesser toxic, more effective regimen. And we could see those results from an oligometastatic. She became a completely curative intent treatment. And I don't intend to stop right away also because of the sustained response she has right now and the curative potential she is in right now. Next slide. So I will ask Dr. Samit Purohit for his experience also, sir, because it is important that we discuss on a public platform these cases and share our experiences because this molecule definitely is different by design.
Thank you, Dr. Akhil. That was a very nice presentation, especially a metastatic case converting into a curative intent. And I think at the outset, I would like to thank Dr. Manish as well for inviting me on this forum. I'll just share my slides here. So can I be given the rights to share?
Yes, sure, sir.
So I believe my slides are visible now.
Yes, sir, it's visible.
So yeah, so these are my disclaimers. And I'll be presenting 2 cases here. The first case is a 59-year-old postmenopausal lady who came with the left breast lump, and she had a hard and fixed ipsilateral lymph nodes, and the biopsy suggested IDC. Her receptor status revealed that her estrogen receptor was 70, PR was 50%, and she was HER2 3+ with a Ki67 index of 30%. PET-CT revealed multiple bony and bilateral lung metastasis, and in view of her HER2/neu 3+ status. So this was actually evaluated outside somewhere, and she had received anti-HER2/neu therapy, pertuzumab, trastuzumab, and paclitaxel, post 3 cycles where she had a good partial response. And subsequent to that, she received 3 more cycles wherein she had a progressive disease where there is an increase in breast lesion and new bone lesions were seen. Thereafter, she was planned for TDM1 for 3 cycles, and a reassessment scan in November 2021 suggested progressive disease in breast and lungs. So this is when she presented to me, and I planned for a re-biopsy, and the site chosen was lung, and where we found that the receptor status again was high, ER of 70%, PR of 30%, and this time HER2/neu was negative. So this is the baseline scan. These were all the metastatic lesions, and this was after continuation of 6 cycles of anti-HER2/neu, and this was after TDM1 where this breast lesion continued to progress, and these were the lung lesions. So the patient was offered Abemaciclib plus letrozole plus zoledronic acid, and this was in November 2021. And in my early clinical experience, this was post 2 months of treatment. Patient was clinically better. There was a reduced breast swelling, and her appetite was better, and she had gained weight. She belongs to a very remote village in Rajasthan, and the last follow-up telephonically was somewhere in April, where she was mentioning that the breast swelling had come down by 70 to 80%, and she was clinically much better. I had requested her for a PET scan, but she has not yet reappeared till now, but I believe she is doing well. So this was my first case. And coming to my second case, this is a 66-year-old postmenopausal lady. She was diagnosed with a breast lump, and the biopsy again revealed an IDC grade 3. She underwent surgery, which revealed PT2 and 2A level status. Extraneural invasion was there, LY was present, and this was somewhere in 2018. She was hormone positive and HER2 negative with a Ki67 of 35%. After surgery, she was offered 12 cycles of paclitaxel and followed by AC, the standard practice. Thereafter, she received 20 cycles of radiation till July 2019. She was offered tamoxifen. However, she developed some sort of intolerance to tamoxifen in the form of deranged liver function. She had some transaminitis. So she was switched to exemestane, and this was till February 2021. A reassessment scan in October from 6 months from then revealed PET-CT revealed a new lung nodule, and a repeat biopsy from that suggested that it was a metastatic lesion, and it was HER2 negative and hormone positive. The lab parameters were normal, and this was the lesion. So at this moment, we know that hormone responsive metastatic breast cancer behaves like a heterogeneous disease. There are multiple disease characteristics despite hormone responsive positive disease. And these parameters, when we have seen, usually quantify for a shortened time to recurrence in early stage, patients who present with a visceral disease or a liver metastasis, patients with a high tumor grade or a negative progesterone receptor status are usually the prognostic factors. So the patient was already on hormone treatment, progressed on a hormone treatment in a matter of 6 to 8 months. So the right choice would be a fulvestrant plus CDK4/6 inhibitor. However, this patient was quite reluctant to receive any of the jabs. So the patient was restarted on Abemaciclib 150 mg twice plus letrozole with calcium and denosumab. And we have seen from the trial results Monarch 3 that there is a significant benefit with respect to median PFS and overall survival benefit as well. When you combine Abemaciclib with NSAI versus placebo plus NSAI, and you see the responses, they appear quite early in the course of disease, and the graphs tend to remain separated. So this is the CDK4/6 inhibitor graph plus aromatase inhibitor. So if you quantify the median PFS, it is twice to that of a single agent, letrozole or anastrozole, with a hazard ratio of 0.54 and a statistical significant value. So if with respect to other parameters, other stratification factors, we can easily make out that irrespective of any stratification factor, all the diamonds are lying on left side of the unity, favoring the Abemaciclib arm. And if we see the visceral disease arm, which tends to do very poor with respect to treatment response, the hazard ratio was 0.56, and the diamond is just overlapping the bone only disease. So Abemaciclib arm was doing quite well in visceral disease as well. Similarly, in patients who were progesterone receptor negative, again the hazard ratio was 0.41. So this tends to show that patients, irrespective of any of the stratification factors, will actually benefit when you add a CDK4/6 inhibitor over conventional aromatase inhibitor, and especially in this Abemaciclib arm, which was doing quite well in the poor prognostic factor group like visceral disease or patients who had a shorter interval of a prior endocrine therapy or progesterone receptor status. So with my early clinical experience in this patient developed in grade 1 diarrhea. This was starting initially 1 or 2nd week of the therapy. However, it did not require any dose interruption, and the symptoms settled by the initial 2 months. The PET-CT, which was done in February 2022, suggested a significant metabolic and morphological regression of the pulmonary nodule, and a partial response was seen. So this was the nodule before, and this had quite well disappeared in the subsequent scan. So these were my 2 cases. So I think now we'll be going ahead with the moderation, and Dr. Vikas. Dr. Vikas, are you there? Gitika?
Yes, sir. I'll
You've
check
lost.
once.
Yeah.
Hello, Dr. Samit.
Yeah, Dr. Rajat.
Hi, Dr. Rajat. This.
Yeah.
With the use of Ramiven, how much is the percentage of diarrhea that you've experienced? Because this is a major concern of a lot of clinicians for the, or maybe I should say, the reservation against the use of Ramiven. So, what is your thought process regarding the diarrhea part? Do you reduce your doses when you're starting, and how much of diarrhea you've reported with the maximum dose that you've used in the patients?
So I would say the trial data suggests around 80% would develop diarrhea. I have seen personally around 3 patients out of 5 would actually develop diarrhea. However, fortunately, in my clinical experience, it hasn't been that bad. I usually add a lot of prokinetics, this thing, Visilax and enterogerminas along with the Ramiven, and I start with full dose. I don't start with a lesser dose.
Okay, right. And even I have seen that the diarrhea is not to that extent. Probably, maybe Indian patients are less prone to diarrhea, fortunately for all of us. So we don't know, but then probably diarrhea is not as much as what it was in the trial data set.
Definitely.
So I totally agree with Dr. Rajat and Dr. Samit's point, because when we had the experience initially with the trial coming in India, the 200 milligram dose, that was some dose which was definitely diarrheogenic, but with 150 milligram twice daily and our common experience with it, it's very quite common that I usually prescribe and tell them upfront that whenever you have the first incidence of diarrhea, take loperamide, and most of them then don't have much subsequent diarrheas. And diarrhea is something which can be managed locally in their settings also. So that's the best thing when we give Abemaciclib, because one thing, the dosing is something which is very, very convenient. You don't have to explain off, on schedule to a village person coming from a very distant area as when to take, when not to take, whether they have taken a 7-day washout period or not. And the next best thing is, even if they have some side effects and they do CBCs and other things, most of the physicians panic when you give other CDK4/6 inhibitors with the myelosuppressions around. With Ramiven, the myelosuppression is not that much, and though no neutropenia, so no need of febrile neutropenias. Diarrhea also, most of the general physicians are very, very well versed. It can be managed locally. So it is comfortable for the patients also, and for the prescribing oncologist also. So see them once in every month, then rather than seeing them once every 2 weekly with the other regimens.
Yeah, I think that's a very valid point, and we are very confident that diarrhea is fairly manageable, and it won't be affecting the quality of life of the patient, unlike the neutropenia with other drugs. So that is one aspect, and I haven't seen to the tune of 80% in my patients. So fortunately, like Dr. Rajat said, Indians are much better tolerating this drug. So,
I have
Doctor, yeah.
I have a case where this patient was actually started on ribociclib by me, and she was a metastatic hormone receptor positive HER2 negative disease, and uh, she was a 70-year-old lady. She's still doing very well, 70-year-old, and you do tell them that, you know, if you have issues regarding, you know, mucositis or any fever, you have to report. This is what was told, and the only issue that she had was, and she was not having any comorbids. The only issue that she used to have is a grade 3 neutropenia, which is very much expected with ribociclib. And over the next 3 to 4 months, she had a very good response also. But from 5th month onwards, she started having very frequent episodes of UTI. And you know that UTI used to be like for 10-15 days, extremely severe. Again, antibiotics, oral antibiotics at times, IV also was given. And then again she was fine for one month, and then again the UTI had started to happen. So I referred the lady to my urologist, and my urologist said that probably, according to me, the neutropenia is the reason for UTI, and you should stop your this tablet, and probably the UTI will be fine. So the tablet had to be stopped actually. Crixana had to be stopped, and she was continued only on letrozole, and the UTI became better. And then this time around, I did not restart Crixana. I actually shifted the patient to Ramiven, and then there was no neutropenia after that, and trust me, there was no UTI as well. So I mean, a case where how important it is for us to not have myelosuppression is what I'm just talking about.
So, Dr. Vikas will go ahead with the moderation, right?
Yes, definitely, yes.
Yeah. So I think the first question which is here is, does the endocrine resistance status of the patient impact the use of abemaciclib?
Definitely, yes, because we definitely have in our common situations a disease even though we believe it's a hormone positive, and we have given endocrine therapy, and we find we have a metastatic situation upfront to deal with because of the endocrine resistance and early endocrine resistance. And especially we have seen this molecule working in a situation where other molecules have failed miserably. The poor prognostic factors, the PR negative subgroup, the high Ki67 subgroup, the liver metastatic subgroup, and also in those who were an early endocrine resistant population. So for me, it is important that we look at the biology of the disease, because the tempo with which the disease progresses, the time of the endocrine resistance is also a very important factor that has been interplayed in various trials the Abema was part of. And that's why that negative um, uh, prognostic subgroups was a characterization for a selection of this highly effective molecule, which has its continuous regimen, which plays a very important role, especially in this negative prognostic subgroup of our patients.
Yeah, so we this is, I think, an edge with abemaciclib over other drugs, that primary endocrine resistance, which was included in Monarch 3, is in this particular subset. Abemaciclib does better, and in my personal experience, I had a patient who was started on palbociclib. This was 3 years back. Patient stayed on palbociclib for about a year and a half, and then he progressed with brain metastasis. And somewhere down the line, I reintroduced abemaciclib in this patient, at 200 mg OD, and he did better. He did quite well for another 4 to 5 months, and then I lost that patient. So, and there have been studies that have suggested that patients who have been on previous CDK4/6 inhibitor like Palbo, Abemaciclib does still work. So, I think that is one important thing to keep in mind. So, how does the selective inhibition of CDK4 versus CDK6 matter, and what does this have on your choice of CDK4/6 inhibitor?
So it is important that when we use a drug, the off-target side effects it has a very important clinical and biological implications for it, and that's why the selectivity of our molecule to the on-target and the less off-target mechanisms make it much more effective. The CDK4/6 inhibitors, probably Ramiven has an edge over it in terms of the lesser myelosuppression it produces, which is an off-target effect of other CDK4/6 inhibitors. So if on a Monday morning I have a case where there's an extensive skeletal mits, I have a reservation of using an off-target adverse events of other molecules, because we don't know that neutropenia becomes a febrile neutropenia and a life-threatening complications. For me, for that, on-target effect of this drug is much more important for it, and that's why it is important for us to choose among the plethora of options we have for the CDK4/6 inhibitors for a molecule to have its on-target effect and lesser off-target effects. And also, I am a great fond of the continuous daily dosing in terms of the off and on dosing in terms of the others, because you have to look for the ECGs in other patients, in other CDK inhibitors, the QTC off-target effects of it. Also, you have to look at, especially you have to look at the endocrine partner, whether you are giving which endocrine partner you are giving, because most of them tend to have the prolonged QTC interactions along with the tamoxifen we use. So I am a quite well fond of the CDK4/6 inhibitor Ramiven in terms of its more on-target affection, more selective nature, and a continuous regimen it has with it.
Yeah. So, in your experience, how important is the delay to chemo, which is achieved by Abema for all these patients?
So for me, again, it is very important because we have seen in past many of our patients that the hormone positive subgroup doesn't have an exact similar response with the chemos as compared to an hormone negative population. And no matter how intensive you give these chemos, those pleural effusions, those hormone sensitive nodes, they don't disappear with the chemos the way it disappears with these therapies. So I believe the CDK4/6 inhibitors, they have a very early onset response and the durability of this response. So with the range of molecules we have right now, and also a good second line PIK3CA inhibitors that we have in our molecules, chemotherapy is something which we never discuss in many of our patients when they are hormone positive metastatic breast cancers, because we know that we have a good range of arenas of therapies to offer. And also the CDK4/6 inhibitors, when you look at the time on an average, the PFS of it, 2 years, you're going to say a patient that you're not going to see chemos. That means a lot, especially in a metastatic situation, especially when the patient does have a response with a single tablets, the quality of life is preserved, their hairs are preserved, their body is preserved, they can lead a normal life, they can plan ahead, and they have good exceptional responses to it, a good disease control rate, and an improved overall survival. That all means a lot to metastatic breast cancer patients, I believe.
Yeah, and besides, it's quite easy to convince a patient to take a tablet rather than chemo. So patient is happy. So, which is the most efficacious of CDK4/6 inhibitors for patients with liver mets? If you compare the data from all these three CDK4/6 inhibitors.
And we have seen in and discussed over multiple discussions that yes, this group of patients is one of the most worst performing out of all the subset analysis when we do for an hormone positive metastatic breast cancer. Once you have a liver mets, that's a negative prognostic factors down and out straight away for upfront. And that's where this molecule works brilliantly, because once you are with liver mets, you would have earlier been tempted to use chemotherapies to get a response and then put them to other molecules. But with Ramiven right now working as beautifully and much more better than the chemotherapies in this subgroup, gives us a good ray of confidence that yes, even though the patient has liver mets, he's not in visceral crisis, we will be using our Ramiven upfront and reserving chemos down.
So I think this is a question which we have discussed previously. However, just to highlight a few patients' attributes or characteristics that will make you choose Abemaciclib right away, whether it's a Monday morning or a Saturday morning.
So for most of my patients, the convenient dosing regimen, the side effect profile. So those patients, especially with extensive skeletal mets, those patients with a CNS disease, leptomeningeal disease, brain metastasis, those patients who are PR negative and endocrine resistant population, those patients with liver metastatic, those patients who have come from a very far away areas also, so making them lesser travel and a convenient dosing regimen, I believe, is something which we all practice a lot.
So just to put it another way, do you have any patients or a group of patients which you would not offer Abemaciclib?
That's something which is I would say that with the available data to deny a CDK4/6 inhibitors in a metastatic breast situation, the only thing I would be those who have a visceral crisis. That will be the situation I will be using chemotherapies. Otherwise, all patients with the CDK4/6 inhibitors, my preference of choice is Ramiven as compared to others.
Yeah. And what are the toxicities would you want to monitor with all these three?
We usually do the complete we look for the neutropenias, anemias, thrombocytopenias. We look for the diarrheas with the Ramiven. QTC is interval which we always calculate and look for whether they are prolonging. Many of the offending drugs concomitantly used along with the CDK4 inhibitors are notorious for the QTC prolongation with it. And that's where we need to look and calculate those boxes very carefully. I believe these are some of the most common toxicities which we usually monitor for our routine CDK4/6 molecules we use.
Yeah, so just like Dr. Rajat discussed his case, so I have two cases here. So one of my cases was on palbociclib, developing recurrent neutropenias, and eventually the patient, after 10 or 11 months of palbociclib, developed pneumonia, for which I had to stop palbociclib, and he was not willing for any other treatment. After that, he was just on a hormone tablet. Even the pneumonia was managed with antibiotics, and he's doing well on only single agent hormone treatment now. The other patient was on ribociclib. Patient received 6 months of ribociclib. He had a good response in the interim scan after 3 months. 6 months scan, the patient at baseline, he had lung metastasis. So there was always some element of breathlessness, which continued, which was improving with time. The 6 months scan actually showed better result. However, 2 days later, I lost that patient. She had a fall in a washroom, and I don't know, it could be an embolism or some cardiac arrhythmia or something like that. But these are two cases which I feel does tell us about the toxicities of that particular drug. So I just wanted to share on this forum. And what is your opinion on Abemaciclib's unique continuous dosing schedule? I think this you have already mentioned previously. So, what is the impact of continuous dosing on patient adherence with Abema? So, I think that has improved in our clinical practice. Final word about this from Dr. Vikas.
I also totally agree, because you don't have to explain the on-off dosing regimen. You don't have to ask them whether how long they haven't taken. It's because sometimes they take 7 days off, sometimes they take 6 days off and start on the 7th day. So it is sometimes very, very tedious for us also to look at those intricacies for these patients. With Abema, you're safe, and that continuous dosing is something which I am very fond of right now.
Yeah, so that adherence, that compliance is not an issue. The T half of this particular drug is around 18 hours as compared to the other two, which is around 28 or 30 hours. So you require a dose breaking in that, not with Abema. So it's a good drug and easy drug, and the data which is coming through does suggest that the overall survival has improved further with it, somewhere closing around 66, 67 months. So I think, and with the single dosing in the metastatic setting and the way it is coming up in adjuvant setting and high risk cases, I think it's a good drug and a drug to stay. And with more hands-on training with this particular drug, I think we'll be more confident in choosing our patients. So thank you, Dr. Vikas, for very apt and very nice answers to all my questions. And with this, I'll thank you all, and back to organizers.
Thank you. Thank you very much.
Thank you.
Thank you, Dr. Samit, Dr. Vikas, for a very engaging discussion on Abemaciclib, how to really go about using this a very important molecule and where to fit in our patients this particular important molecule. Thank you very much. So.